Welcome everyone to Office Hours. I'm your host, as usual, Stuart Newsom, and our topic is autonomous E&M coding and breakpoints that drive RCM outcomes. The title was so long I couldn't even say the first word. But that's kind of the buzzword now. It's autonomous coding, and so we're going to kind of discover, hey, is it possible for E&M? What are the ramifications for that? So I'm joined today by two coding experts. They got enough credentials to fill the bowl of alphabet soup, trust me. But they got Julie Graham with us today, as well as Susan Eisenhower. Now, both of them are senior coding managers here at Infinix. Ladies, just want to see if you can tell us a little bit about yourselves. Julie, why don't you go first?
Yes. Hello, everybody. I'm Julie Graham. I have been with Infinix since 2022, or is it 21? I'm sorry, I just blanked out. I've been a coder since 2008. I handle compliance, auditing, physician education, coder education, and yeah.
All right, Susan.
Hi, good afternoon, everyone. Apologize ahead of time. We're having technical difficulties with the camera. Worked a minute ago and now it's not. As Stuart said, my name is Susan Eisenhower. I've been with Infinix um, for a minimum of 5 years, probably a little bit longer because I did do some PRN work with them. Multiple credentials, medical and coding. I am currently one of the senior coding managers. We handle on my teams compliance, edits, rejections, um, all things back end in the denial space.
Awesome, awesome. So glad to have both of you on. Sometimes we have just one guest, but today this is such an impactful topic. We needed two, right? But we're not going to necessarily go over the logistics of how to code or the mechanics, I like to call it. I think that's been, researched and discussed and taught ad nauseum, so to speak. But today, we're going to cover something that's brought a lot of skepticism around autonomous E&M coding. We're living in a world where AI is everywhere. Doing some automation is everywhere. So there's good reason why there would be skepticism, especially when it comes to E&M coding. The mechanics can be automated in many cases, but as we all know, there's a large degree of subjectivity around E&M coding, particularly around the risk component. So that subjectivity and the other subtleties that I like to call them is still demand a tech-enabled human-in-the-loop model where coding specialists handle exceptions, protect defensibility, and keep the process honest. So we'll walk through the breakpoints that shape real-world E&M coding performance, such as documentation quality, workflow design, payer edits, and downcoding behavior, underpayments, overpayments, overcoding, and audit exposure. I can go on and on, but because those factors determine whether revenue sticks and whether the process scales. Now, as always, we'll leave time at the end for Q&A. So if you have any questions, I encourage you to drop them in the Q&A panel below that's here in Zoom. Also, welcome comments. If you have any experiences regarding what we're talking about and you say, hey, I can add to this. So just, drop the comment out there and we'll read it out loud for everyone to hear. So we'll either work them in as we go, or we're definitely going to save some time at the end for them. So with that, ladies, y'all ready to jump in?
Yes, sir.
Absolutely.
All right, all right. So, Julie, I'm going to ask you first. Let's starting with documentation, because
Okay.
we've I've been doing this for 30 years or so, and I've just it doesn't matter if it's technology from 1995 or now 2026, it's still all about documentation.
Yes,
So when
always.
when documentation does not support the level build, I mean, that's kind of a loaded question. What are the most common gaps you see in medical decision-making support, and what provider education actually changes outcomes instead of just adding words?
Yeah, that's such a good question. And yes, documentation drives everything. The most common issue that I identify And E&M audits is overcoding, and that's particularly among cardiology providers, since that's my niche. That's what I stick with, and that's where my specialty lies. Many cardiologists, they select a high level E&M code. However, the documentation does not consistently support that level build. A typical exam involves visits for exacerbation of a chronic illness with medication management, and this scenario generally meets a level 4 criteria, yet it's frequently coded as a level 5. But once a physician understands the specific parameters required for a level 5 service, they often recognize opportunities to strengthen their documentation. For example, the difference between documenting that a condition is a exacerbation, moderate, versus a severe exacerbation, which carries a high risk, can be significant when clinically supported. And so providers also see the importance of clearly documenting all treatment options discussed and considered, which are sometimes unintentionally omitted but materially impact medical decision making. So when caring for patients who may require invasive procedures, there is often a legitimate potential to support a level 5, but only if it's fully documented. Providers do an excellent job of addressing general procedure risk. However, a high level E&M requires the decision making risk to reflect patient specific factors. So those generic procedure related risks alone are not sufficient, as all invasive procedures inherently carry a baseline risk. And detailing that individualized risk consideration strengthens the documentation and more accurately supports the level of service build. And so,
Right.
when I talk to them about this and help them understand, we're looking at the elements of what coders go by when they select those levels. It kind of links it all together for them. I don't know how much education providers get on the E&M sector of selecting levels. But when they see the elements and what generally goes into this, it kind of is like an aha moment for them. They can say, oh, okay, I see there's an opportunity for here for me to improve and to support my level 5. Sometimes a level 5 is obvious, and so, but these are the times where it's not. And often when I talk to those providers and show them that, they're like, yeah, I missed the mark on that. So those are the things I look for. When I do audits, I really focus on level 4s and level 5s. And some level threes. I just want to make sure they're not undercoding as well. But those are the things that I typically look for in the kind of education I provide to the doctors on how important the documentation is and how it supports those levels.
Yeah, because it's really about subjectivity. That's why I was mentioning
Yes.
earlier in the intro. There's
Yes.
especially in risk. And when
Yes.
doctors look at the table and they understand, oh, hey, the words matter, extreme exacerbation versus just plain exacerbation is the greatest example. They just got to tweak their documentation that it supports that. But then when you come to say like the risk table and you got that prescription meds is sitting right there, right? And where it's going to be a
Yeah.
level 4. Well, I've talked to some physicians and they could be lower because the prescription med management probably wasn't that risk heavy. Where others may say it should be a level 5 because the risk management is based on comorbidities and
Yeah.
mortality to the patient, it could be much higher. So still there's a level of subjectivity, and that's why I think, that human in the loop is so necessary when we're talking about autonomous coding for E&M. Autonomous coding works perfectly for things like radiology, maybe cardiology, orthopedics, because you're looking at a procedure. But when it comes to E&M, it's definitely going to require, someone looking at it from an exception standpoint. And most physicians when they're and I don't know if I'm stealing anybody's thunder down down the way here, but it's almost like they're writing for someone else clinical to read the document. So
Yes.
it's that's
Yes.
why that's why it's so short sometimes. So and with that, Susan, I'm gonna, throw the ball over to you now.
Sure.
But from your back end view, so to speak, how does this surface later in RCM, for instance? Everything that Julie just discussed and the comment I just made, for
Mhm.
instance, from your edits, denials, and compliance perspective, right? Because that's kind of where you live.
Sure.
How do E&M coding problems typically surface downstream? When upstream fixes create the biggest reduction in rework and delays.
Sure. So where it impacts downstream is circling back to a lot of what Julie said. Um, if it wasn't documented, it wasn't done. If the provider's saying it's a level 5 and we have a primary diagnosis of cough, that's going to be an automatic flag when the insurance companies go and process that. So it's proper assignment of diagnoses, putting the majority of the work that was performed at that visit as the primary diagnosis. You could have COPD with exasperation and chest pain. Well, we've got COPD as the primary diagnosis. The chest pain may or may not be related to that COPD. So again, proper provider documentation and proper sequencing of the diagnoses from our coders in the very beginning. A cough is not going to give you a level 5. A
Right.
cough with is usually a sign or symptom of
Mhm.
a more definitive and specified diagnoses. So back end wise, it affects us and slows down our money because of sequencing of diagnoses that are incorrect, um, non-proper documentation, back to medical management. Well, hey, I told the patient to take over-the-counter acetaminophen. Oh, okay, OTC is not prescription medication. Now,
Right.
if it was acetaminophen 800 milligrams, that's a prescription through a pharmacy. Um,
Mhm.
Improper uses of modifiers. If we've got an office visit, and I'll circle back with Julie because she mentioned cardiology. We've got a level 5 office visit. We have a EKG. Maybe we took them right next door to the echo department or echo lab and did another procedure, and we leave off modifiers. Well, your E&M will be bundled into your procedures.
Mhm.
Yes.
So it's
Yep.
it's this the work done upstream, if not done properly and within compliance, is going to affect downstream edits, denials, out and outright rejections from insurance companies. So then we're taking a second and third look when the issues could have been corrected on the front end.
Yes.
Yeah, exactly. And I do think also, even taking it a step further, it could lead to those recoupment letters,
Oh,
because E&M,
absolutely.
where it's
Absolutely.
overcoding.
Recouping.
Yeah, not necessarily
Oh,
undercoding, even though they say they pay back undercoding, but there's such a small percentage. But
Yeah.
you got the money, but you don't not keep the money, which I
sure.
think we'll talk
Sure.
about a little bit more later for sure. But it's
And undercoating's just as egregious as overcoating.
mhm, mhm,
It's still
absolutely
outside of compliance, and that's the whole goal of what we should be doing as coders. We need to be within compliance. Our rules protect us. Our coding guidelines are there for a reason, but we're only as good as the documentation that's presented.
right, right. And I would also say that there's money left on the table.
Oh,
Again,
Yes.
absolutely.
so
Uh,
we'll probably dive a little deeper into that as well as we move along with the conversation. But Julie, now to how this actually works operationally, and at scale, in providers selecting E&M coding environments, what does a review net look like that protects revenue and compliance without forcing 100% chart review?
Yeah, so that a strong review and a strong review net and provider selected E&M environments use targeted risk-based oversight rather than 100% review. So this typically includes random sampling for each provider and focused reviews triggered by data trends or past audit findings. So if I've done an audit on a prior physician that, chose a lot of level 5s and that documentation didn't meet that. And I've done the education with that provider. the next time I'm reviewing, maybe in the next, every quarterly, then I'm going to look at that provider again. I may look at his documentation or select to do a few more of his rather than a physician that scored well or understands the parameters and the elements a little bit better. And
Mhm.
so I combine that with ongoing education and follow-up audits for the outliers. And this approach protects the revenue and compliance while keeping the chart view workloads manageable. I typically do like maybe 10 charts per provider. If a provider's done really well, I might not do that many. I recently did an audit where there was a lot of undercoding. I could tell immediately these doctors were very conservative in their approach, even when they were doing prescription management. Yeah, these patients were coming in with CAD, coronary artery disease that was exacerbated, or congestive heart failure that was exacerbated just a little bit. They weren't, they weren't not having a problem. And so the doctor either increased their medication or prescribed a new medication, but these physicians were choosing a 99213. And so again, I just went back to them, explained, spoke with them, showed them the guidelines that we follow and help them understand that, hey, you're leaving money on the table. You can make yourself some more money. And hopefully by that education, the next time that I review them, maybe I'm hoping to see some improvement next time. But, that prevents you from having to do some large 20, 25 chart audit or something like that. And we
Mhm.
just keep that going, every 3 months or so.
Yeah, you don't have to do it such a large scale. I think to your point, you're going to get the idea after reading one or two, three charts. You're going to
Yes,
have kind
that's
of an
the other thing.
idea of
Such a good
what the
point.
trends
Thank
are.
you.
Yeah,
Yeah, I
yeah,
can tell in a few charts. Okay, I can see where this is going. So yes, that's such a good point. Thank you for
right,
bringing that up.
right, right. So, and on that, is Julie, you were talking about, the undercoding. Undercoding leads to underpayments. So again, I'm
Yes.
teeing this up for Susan. So let's talk about that hardest leakage to catch, right? And it
Yeah,
is underpayments because it's not a denial.
No,
So how are you going to know if it's underpayments, right? How are you going to catch that? Well, it's through this
sure.
repetitive documentation, but underpayments are hard to see and hard to recover. So what signals tell you underpayments is happening in E&M, and how do you prioritize what's worth pursuing?
Sure, absolutely. And again, it's what Julie is speaking on educating our providers, you know, using such certain verbiage of this is a chronic condition with exacerbation, et cetera, et cetera. A lot of our on our back end, it's best to do like pre-audits, right? Before claims go out to our insurance companies, back to making sure we're sequenced correctly, et cetera, adding appropriate modifiers and such. Underpayment wise, running random per provider, running random reporting for them. Hey, a lot of 99213s were coded, but hey, we've got, underpayment because this insurance company, the contract with the provider is supposed to pay this amount. Um, Modifiers, hey, they're all present. Why is this being bundled into that? Yes, you can look at EOBs and such to determine that when running your reports, but if you've got AI involved, AI will go ahead and the work that we feed it, the
Mhm.
LCDs, the medical necessity information that is needed. AI can pick up trends, pick up
Mhm.
patterns, and
yes.
dump certain claims into a work queue that needs to be looked at specifically for an underpayment. Going back to undercoding, hey, we've got this diagnoses that, according to this payer's LCD, should be big medical necessity,
Mhm.
but there's only a 99213 coded. So you can hit things on the front end prior to our claims going out with the help of AI. That's where it would be profitable and most useful in the beginning. And it can also kind of help us in the back end. We get the payments in, and this payment's kind of low compared to what this provider's contract states. Let's go
Mhm.
ahead and take a look at it, and then we pull in collectors, we pull in billing experts. Some offices their coder is their biller and their collector. So they'll have all that information there. You get to larger medical groups, larger provider clinics with 6 and 7 provider specialties in the same space. You may have separate departments. So communicating between those departments, working one-on-ones, bringing to them the patterns, or, hey, provider X, we've got here that you've got several chronic conditions in exacerbation that's documented, but you're only doing a 3 when this could be a 5. That goes to Julie's point on educating her providers and documentation. So it's a full circle. We're always going to need that human component, but AI
Yes.
would be very helpful in here is your trend. They spot
Right.
trends before humans can spot those trends.
Yeah, exactly. And that's where AI is really just such beneficial. And I think autonomous coding for E&M can work, but it's still going to need human in the loop. And I'll talk a little bit
Oh,
about that at the
absolutely.
end about how it can work, the advantages. But one of the advantages you just hit on is it's going to escalate, what a human could do because you can only read so many charts at a time. Whereas you
Mm,
can actually train these machine learning models to read the documentation, and then it's going to then compare to, well, what was the diagnosis code you used? Well, you only
Mhm.
put one diagnosis code, which is the chief diagnosis code, the reason for the visit, that's the rule. But you may also have some comorbidities. You may have some social
yeah.
determinants of health
Yes.
that will bump that E&M code up because the severity and risk increases. And again, and I think a lot of providers undercode on purpose because
They
they
don't get
don't
audited. Yeah.
trust they don't want to get audited,
Yeah.
and they don't, which means they don't trust their clinical judgment. And that to me is crazy because they should trust they're the clinicians. They're the ones that
Yeah.
know exactly what needs to be done to remedy the problems that the patients are having. But yet everything's being driven by the scare of being an
Documentation.
audit, so they're going to downcode. That's why I think the bell curve, that everyone uses to kind of compare everyone to, well, that yeah, and Medicare has one, all the payers have one. It's that E and
Mhm.
bell curve, and you're supposed to compare yourself to where you are, and if you're above it or below it, then you're susceptible to audit. Well, I'm under the mindset that that bell curve is based on historical data, so the bell curve's wrong because everyone's downcoding
Great.
on purpose, right?
Great.
So, so it's like, who do you trust there? But I think if one of the things that I used to tell providers when I was educating them was you just need to trust your clinical judgment and document
That's so
appropriately
good.
so the
Yeah.
coding is done appropriately because coding is the language that payers use to understand what happened. And if you're not coding it correctly, and I'm talking diagnosis codes too, then the payer is going to get
Yes.
the wrong impression and pay you appropriately for that. So,
Specificity of
yeah,
Big time
those
specialist.
diagnosis codes.
right, right, exactly. So, Julie, we're now
Can
going
I
to
can
shift
I
to,
add a caveat to that
yeah,
when
yeah,
you're just talking on that? So it's not just the specificity of the code, where the coding guidelines come into, and where a lot of providers, they're not coders,
right,
right?
Right. Yeah.
We can teach them the necessary components that need to be in their documentation. But as coders, we need to understand our guidelines. We need to understand code also, code in addition to combination
hmm
codes.
hmm
Yes.
LCDs play a big part in determining the levels that you're going to get paid at. So
hmm
it's not just one issue. There's several issues, and all those issues need to work together in tandem. Get the
right,
Yes.
claim coded correctly the first time, and then your payments come in a regular time frame. So
right,
AI helps with that, but the human component is more important than that AI, because the
right,
humans have to program or feed the information. So the stronger the knowledge of that coder, of that office manager, that biller, that collector, the easier it'll be to collect the monies that we're supposed to collect, and to see where those underpayments may be lying also.
Right. Exactly. Exactly. So, and I do want to shift now to sustained improvement because sometimes improvement can be very episodic. Providers will get a little better
Yeah.
and then get back into bad
They,
habits. So,
yep.
Julie, I kind of want to talk about that. What are the most effective internal audit approaches, for E&M coding today, including, how often to audit, what to sample, how to turn findings into sustained improvement.
That's going to be the focus for that is going to be on structured sampling, consistent frequency, and deliberate follow through. So I kind of touched on this a little bit when I was speaking freely on my last question, but a lot of organizations use a risk-based audit. And so that's their strategy. They prioritize high volume providers, high complexity visits, new clinicians, and historically problematic areas. But you can do a risk-based audit. That's always fine. But to Susan's point, that proactive audit is going to be so beneficial as well. It's just determining for your practice the cadence. A office that has more providers is going to be a little bit harder, might be a little bit more challenging as opposed to an office that has one or two providers, to determine that cadence. But a common cadence is the quarterly audits that I mentioned. And then we supplement that with focused reviews when new patterns are emerged or when guidelines change, especially when the guidelines change. So,
Mhm.
especially when we went from when the E&M went to MDM, when you no
Mhm.
longer had to worry about HPI, all the, how many is this and how many is that. And, in
And
your
I'll
exam,
check the
did you do
boxes.
8? Yes. Did you do 8 systems or did you do this? And so that was definitely a huge shift, a very welcomed one from a coder's
Hmm.
perspective, but a huge shift. And so that for sampling, a balanced method works best. A random sample to assess overall compliance, plus targeted samples for problem codes, like I mentioned before, your high levels, your 99223s, your 205s, your 99215s, even quite possibly, the 214s, the 204s, your 99222, which the 99223 and the 99222 are inpatient hospital consults. And so
Hmm.
I probably see more 99222s than or excuse me, 23s than I do of the 99205. So and then along with that, high utilization outliers or documented denials. That's a big one. A lot of these insurance companies are starting to push back. I've seen more and more denials recently where they've requested records on those high levels and then they read the records and then they don't accept the code that was submitted. They're telling you, no, this doesn't meet the guidelines outlined in AMA CPT. Please review and submit a corrected, change the code basically.
Hmm.
So most teams, like I said earlier, we select 5 to 10 encounters per provider cycle. We adjust upward or downward for new or high risk providers, and that seems to be a good little happy medium. And then we turn those findings into sustained improvement, which we close the loop. So that means providing individual feedback sessions. Sometimes it could be around the table, kind of like this, or it might be individualized meeting with a certain provider. Some providers want that. Other providers may not be as interested in having that done. And offering actionable education tied to real documentation examples. So I like to bring those documentations, those visits with me and say, hey, let's talk about this. Here's what you documented. Here's how I interpret it based on the guidelines. Can you help me understand your thought process here? Or, that's where we talk about, improving that documentation, saying, hey, did you leave something out? You wanted a 5. So did you accidentally omit some or forget to include something? Doctors get
Hmm.
busy, they're thinking of a million things in their head, and it doesn't always get down on that paper.
Right.
And so, embedding results into provider scorecards, which I do that on my audits. It's an automated thing, and so they can see their score. It scores their E&M, their the diagnoses, and so I can provide that feedback too. And all the great things that Susan mentioned about diagnosis coding. I can go over that with my providers too, because that's just as important. Those, going back to the cough example, your diagnosis codes support that medical necessity there and supporting that level. So it's all encompassing. Like she said, it all works in tandem. So the goal isn't just catching errors, it's building coding accuracy and documentation quality into daily practice. And not, Susan, I'm sorry if I'm going to steal your thunder here if you've said this, if this was your idea. No fluffing the note. We don't want
No,
Yeah.
we
no.
don't want 2 or 3 pages.
More
No
does
fluff
not
fluff.
mean more.
Yeah,
So
exactly.
none of that. Just make sure that it matches the patient's clinical situation for
Yeah,
that day.
exactly. I've seen a short paragraph substantiate a level 5 service. And
Yes.
100%.
yeah, so
It's your
it does,
buzzwords. It's
yeah,
your buzzwords.
it doesn't need to take a whole lot of content. It's just keep it short and simple. Um,
The KISS method. Yes.
right, right. And kind of speaking of that, this kind of goes into, the last question I have, Susan. It's all about, how does AI, how can we make that practical in our day to day? So just pretty simple question. Maybe it's not such a simple answer, but what would make AI genuinely useful to your team day to day?
Establishing the trends that they're seeing, the undercoding, the overcoding. It's great for compliance because the AI or the instruments of AI, whatever program you want to go with, if they are reviewing the documentation and they've got built into their back end program, the LCDs, the NCDs, something simple as, okay, you have coded this, but here's a guideline where this needs to be included. If you're saying pneumonia and you've got the culture results, where's the culture result? Where is that? Was it E. coli? It's the supplemental information that can be extracted from that office note with the use of the programmings, then it's documented, it's picked up by AI, it goes out correctly the first time.
Right.
LCDs are important, the NCDs are important, the NCCI edits.
Yes.
You don't add a modifier just because you want to override the edit. The
Yeah,
documentation needs to support that use of a modifier. And not just the
absolutely.
laterality, but your 25 modifier on your E&Ms, your 59 and XU series. Big thing going on right now is telehealth. Everybody's been aware back and forth, this ruling, that wording. Finally, we've got something at least for the rest of the year. Okay, well, what insurance company wants what
Mhm.
modifier? Do they want 95? Do they want GT? What's your place of service? All that needs to be built in for per payer specificity.
Yes,
We have general guidelines, but each payer may have a separate guideline.
that's such a
Perfect
good point.
example is OBGYN. Um, some office visits, if it's for birth control, they want a TH modifier. If you're given an injection with that office visit, some insurance companies don't want the depot code, the J1050, I think it is. They
Mhm.
want a J3490. um, so it's the different payer guidelines you need to use. So when the information is programmed correctly, it would help us reduce our compliance risk. It would promote the accuracy. It identifies patterns and trends that may take a human being a little bit longer to catch on. I mean, a couple days makes a big difference when we're talking
Yeah.
about timely filing.
Mm.
Um, so that's where I think it would be most useful. It would validate the qualifying visits, right? Pain management. You're going to go in and perform injections on a patient. Well, have they had conservative treatment yet? Where's that document? Did they fail conservative treatment?
Mhm.
Um, we could go on and on,
Oh
but
yeah, there's
Yes.
all kind of applications there. Exactly.
so, so it's we always need that human component.
Right.
AI is not going to take over everything. Will it be beneficial for easy-ish cases, like you said,
Mhm.
radiology, lab is a huge one.
Yeah.
Yeah.
Sequencing the informations for lab. If you're ordering lab for just a preventative visit, but then you want hyperlipidemia, or the patient's got hyperlipidemia, high blood pressure,
Mhm.
diabetes. Okay, well, you've got all that on your order, but how are those diagnoses being put into that system? Because your
Mhm.
Z00.00, that may
Right.
be listed last, where it should be listed first because that's the primary reason for the lab. Then the patients get a bill because everything went to their deductible. And
Yep.
like I said, a
Mm.
lot of scenarios,
Yep.
lots of scenarios, but it will cut out the component of a human coder on the simple stuff.
Right.
We
Right.
still need, even for for E&M, you're always going to have a human being.
Right.
For billing and collections, you're always going to have a human being. But
Right.
if it's loaded correctly or fed correctly, the information that it needs, revenue will start flowing in a little bit sooner,
Hmm.
and there won't be such a human touch. Save your human beings, our coders, our collectors and billers for the more complicated issues such
Yes.
as surgery and heart caths and deliveries.
Right. Right. And
Yeah.
that's where, it all comes together because that's kind of our approach here at Infinix is this tech-enabled approach, because we are an end-to-end services company and we definitely, in my opinion, are on the cutting edge of developing AI agents and solutions that do exactly what you just described, Susan, and that is taking some of the routine, some of the rudimentary stuff, even some complex stuff. I mean, we can actually handle some complex stuff, but then you have that the human specialist gets involved and spends their cognitive reasoning more on a complex situation rather than just task after task after task, like you're a
Yes.
hamster in a wheel. So,
Mm.
so I do think that it's possible to do E&M autonomous coding. I've been involved in that kind of work before. It's out there already in a kind of a way. It's not necessarily AI, but it's kind of goes back to the check boxes that Julie was talking about. If you had this, it was very easy to quantify that and get to a certain level. Still, risk is a big problem. But I do think that you can use AI to actually look at the record and identify this is the diagnosis code. It can actually, and if the record's written correctly, it can determine whether it's, the complexity of that diagnosis code. I do think
Sure.
that the autonomous coding, we can build an AI agent that actually looks at how much data is being reviewed. How many lab tests? What are the little nuances about those lab tests and whether you can
Is
counter or
there an
not?
interpreter?
Yeah, is there an interpreter? Exactly. Is there and then the risk part, I think it can actually look at, um, you know, payer behavior, because you have to train these models, these learning
Yes.
models, and with the right governance, because that's another place that human specialists are going to be needed, is who's going to audit the AI. So you have to
Yes.
have mechanisms in place to make sure that they're doing correctly because they don't learn on their own. I don't care how
Mm-mm.
many times people may say, "Oh, AI learns on its own." It doesn't, or it hasn't yet. They haven't figured that out yet. But what it can do is basically have someone look at that information, look at those models, make sure it's behaving correctly, because it's all about the behavior. And if it's not, then it just course corrects. And so it's going to take constantly governing. So I do think autonomous E&M coding the way that I am imagining in my head can be done because I know there are solutions out there, but I wouldn't necessarily put them in the autonomous E&M coding category the way I think it should be done. But it's still going to involve those human specialists that's so much needed. And even in normal autonomous coding in general still needs some human in the loop for that reason.
Oh, absolutely. Well, we all know too in coding that changes quarterly. Sometimes that changes weekly.
Oh yeah,
We get quarterly updates on our Hicks picks. We get weekly updates on uh, new services. What used to be experimental is now going through tons of clinical trial, and now it's no longer experimental. If you're
right,
not auditing your AI, well, how are they going to know that that's no longer experimental? Because
right.
experimental has a completely different code set that needs to be used.
Yeah, exactly. And even the payers, when they make changes, they don't tell the people adjudicating the claims that the change was made either. So you have that problem
Well, that's
sometimes,
where
and
it
then
would
the
be
payer would.
beneficial. That's where it's beneficial. Also, when you were talking about the payers, that's one of the things that we can do upstream and downstream
Mhm.
to manage the denials.
Right.
Get on your payers' websites, sign up for their newsletters, stay informed with OIG. OIG is going to literally tell you
Yes.
what they're getting ready to
Yes.
investigate next.
Yes, they are. Yes, they
Yeah,
are.
yeah, yeah.
So
Read
the
the cover
information's
letter.
out there. It's just the time to grab that information. That may
Right.
be a way for AI to go. Hey,
Oh
United
yeah.
Healthcare just changed their policy,
They can consume that
or the
information and
OIG
can,
is doing
yeah,
this.
yeah, it can consume that information and summarize it for you, hit the high points, the things that need
Yep.
to matter the most. Um, well, that's all the questions that I have. We are running a little bit over, but we do have a question and a comment. I'm going to read the comment first because I think it is an interesting comment. I really appreciate this from Galena Roper. So, uh, states that another example for overcoding is where a provider counts work from a minor
Yep.
procedure towards selecting the E&M level. The problem
Ah,
is
such a
that
good point.
yeah, it
Great
goes on to
point.
say
Double dipping.
the problem is that the procedure code already includes the pre-service. Yep, and the inter-service and the post-service.
Yes,
Yes,
ma'am.
that's that global fee period. So if the provider then adds those same elements against towards the E&M level, the visit becomes overcoded because the same work is being counted twice. Absolutely. And
Yeah,
same with the
double
labs
dip.
and the amount of data. So this is why only the separately identifiable work and included in the procedure code and can be used for E&M level selection. So that's an excellent comment.
Wonderful observation.
Yeah,
Can we
yeah,
say
yeah.
mic drop, Galena?
That's
Yeah, big time
right.
mic
Right.
drop.
And then we have a question. It's from Chris Woody, and see, you mentioned training your AI to know LCDs, payer guidelines, local knowledge, et cetera. Where do we start? Does Infinix have an AI agent tool? What action do we take to start exploring using AI with Infinix? So yeah, well, I'm going to kind of answer that is you basically start with if you're training AI and the learning models, you really have to start small. It kind of goes back to what Julie was saying. It doesn't take a lot of records for it to kind of see the repetition. And then you run tests on how it outputs. If that output's wrong, then you go back and look at how you trained it. So you really kind of start with maybe one provider, maybe with one facility if you're a multi-facility type of a practice. You start with definitely looking at if it's a targeting 99215s for overcoding or maybe 212s for undercoding. But the starting small is kind of the name there. And also, at Infinix, we do have agents. We have agents that do prior authorization. We have agents that capture data off of documents and put it into your EHR. We have agents that look at the denials and predict what your recovery is going to be from those denials. And through all of our platforms, we have orchestration, where we have an agent that's actually orchestrating the work. It determines what the AI agent is going to do and what the human specialist is going to do. And that right there is one of the biggest things that I think Susan was alluding to as well. It just makes it faster. Is you don't have to spend that cognitive effort or that energy going, okay, well, I need to schedule this out and see who's going to do what and what workload they're going to have. The agent actually does that. So it's really more or less a workload management type of a way. So there's many applications that can go into that to building that. So if you want to know more about that, then Chris and anybody else, I encourage you to reach out to Infinix. You can find a lot more information about what we discussed today and much, much more because we are in RCM at Infinix.com. We have articles, we have case studies, We have solutions. We have thought leadership. We have a ton of episodes like this you're listening to live that you can watch on demand. So I encourage you to go out there on our website. And then when you want to contact us, just click request consultation and we'll be happy to talk to you. Um, so with that, Julie and Susan, thank y'all for coming on board. Really
Thank you for
Yes.
appreciate
having us.
both of you
Yes,
being
thank
here.
you.
This was, an excellent, very comprehensive office hours for us. And I want to thank everyone else for joining and sticking around. I think the number only dipped by about 5 people when we got past the bottom of the hour, and here we are 10 minutes till, and we're still going strong. But I really appreciate everyone sticking around with us. And again, uh, we're going to have more office hours. We do this weekly. So with that, we'll see you next week, and everyone have a safe weekend.
Thank you, Stuart. Thank you, guys.